Good morning. It's my pleasure to introduce our next speaker. About 2 years ago, when we were on the same venue, Dr. Chang came to speak, and he was warmly received, and he had some great information for us. And he actually came up with the concept 2 years ago that we would set up a scientific advisory board, which Dr. Haley, who you just heard, chairs, and Dr. Chang is one of our executive members as well. So I wanted to thank him for that inspiration. Dr. Chang is the Professor Emeritus of Pathology, Pharmacology, and Toxicology at the University of Arkansas. He's also the Director of Pathology at the graduate program for the University of Arkansas Medical School. He is a member of the advisory boards for the NIH, FDA, EPA, NIOSH, and the NIEHS in this country. He's Director of Environmental Health and Occupational Medicine for the nation's health research institutes in Taiwan. Again, I wanted to welcome Dr. Louis Chang all the way from Taiwan, from the other side of the globe, by way of Tijuana. Right?
As Dr. Fisher pointed out, that we have just set up a science advisory board. The idea is to put science together behind what we claim, rather than we just quote someone else's work or how we feel or derive conclusions by logic. Science follows logic, but science is not convincing by logic alone. So as you see that our advisory committee now consists of world-class scientists, maybe except myself. And at least for myself, I am not a member for the association, for the academy. I was asked to, but I declined for one good reason. I like to help or get involved and participate in this academy's actions, activities, without being a member, but as an independent scientist. And for that fact too, that we are not on any salary, any pay for what we're going to say, except my airline ticket and hotel, this which is not coming to my pocket. And I feel very good about that, because that truly reflects why we are here. We are not here to be paid. We are not hired guns. We are here to speak the truth and find the scientific evidence. Yesterday, we do have a representative from FDA, and I thought that she was going to stay through today. That's why I immediately add a few slides. As you will see, that my presentation will have several slides in addition to what you got. But that's okay, because those slides was intended for her. Because I have worked with governmental agencies, most of them, and I know how governmental mentality is. They have some basic questions that academic scientists will never ask. And they have certain positions that general public will never understand, because they have their so-called rule and regulations, policies, so on and so forth. But I like her to see some of the slides so that she can bring a message back. But yesterday, because she told us that she has something important to go back to Washington, and she left. But we promised to give her one of the CDs, and then she could look into that also. And two of the slides that some of you may have seen before, I apologize, but no problem to revisit why I, as a scientist, not just personally, but as a scientist, feel that dental amalgam containing mercury is a health risk. And I particularly use the word risk. Okay. Looking at the program, you see it's very diversified. The idea is, again, that I advise the academy here, let's don't single out something and keep pounding on it again and again, patting each other on the shoulder every time, say, yeah. Let's look at science in a broad sense. If mercury is what we're concerned, mercury is a heavy metal, let's look at some other heavy metals. Do they have anything in common? It is difficult for anybody to believe only mercury does that. None others will. But also we, from other metallic actions, learn something about mercury that we may have missed. And looking at the program, you just heard Boy Haley very impressively demonstrating from microbacterial actions to metallic to other dental issues relating to health that we should be concerned. And I will be talking to my colleague here, Mickey Ashler, that both of us is in a metal specialty session at the Society of Toxicology, and also on neurotoxicology. I have produced 8 textbooks on neurotoxicology. But today, because Mickey is here, I cannot want to take that risk of talking neuro, so I shift my base to mention a little on cardiovascular. And you heard something about cardiovascular from Boy Haley earlier that set up the stage. When we're looking at health aspects, when we're looking at mercury, the simple way to think immediately is Minamata Bay disease. Neuro problems. Is that all? Mercury is a systemic toxin. It affects many, many organs and systems. And cardiovascular is one, is often. People don't pay too much attention to it because the neurological problem and the renal problem take target attention. So today I kind of bring in a little information on that. And also we'll relate that to another metal, arsenic, which is a global toxin now being considered. And how would we learn something from arsenic's action and reflect us to think about if we have a mercuric problem, what kind of issues should we pay attention to? At any rate, as you know that I am now in Taiwan, I help to set out the environmental health and occupational medicine at the NHRI, the Taiwan version of NIH. And I'm the founding director, and I'm still holding my professorial position in pathology at UAMS. And with the background of pathology, toxicology, and public health, it broadened my vision on looking at things, not only just on health aspect or scientific aspect, but also on political aspects, because that is a governmental organization. Therefore, I could address or could either sympathize or understand how sometimes there are gaps in communication. A lot of people is talking about risk assessment, but the more important thing is risk communication. How do you communicate for someone to understand there's a risk? We all believe in it. How come others they hear what you say, but they're not listening to you? And that's the thing that we try to work out, and I hope I could help the Academy on that. Mercury is not just one thing. It is a family of relatives. Each of them do some bad things, but in a different way. So because a lot of colleagues here are not so-called toxicologists, scientists, basic scientists. So I much rather use terms that people could understand rather than the speciation of this and that. I mean, I don't want to feel glorious. I want to communicate, you know. So people know, actually they have 3 cousins, the elemental mercury that easily vaporizes what we are talking about when we're addressing dental amalgam. Inorganic, organic. People always screaming about Minamata Bay disease are the organic version of that. Amalgam, vaporize, and then many times a divalent inorganic mercury, industrial use, and on food products, many times they are organic moiety. These three cousins of mercury family, they interchange, interconvert. So don't believe it either that when you expose to one type, that does it. They could interexpose. I represent United States going to Minamata. I was the U.S. scientific representative member there. And the industry at that time denied the whole thing, of course. But they have their base. We didn't do it. Because what you guys find on pathology is typical of methylmercury poisoning. We discharge inorganic mercury into the water. So it's not us, they are different. They're right, they're different. But they could interconvert. Biomethylation. And likewise, others, from vapor it should be a zero, okay? Into inorganic form back into methylated form. So this interconversion again become difficult sometimes. And therefore when we do metal analysis and metal related research, my dear former research assistant flew in from LA this morning. She made those slides for me. She now is a PhD student in USA, just to see if I use her slides correctly. We do speciations of metals whenever we look into any metallic problem. We don't just look at the metal in the tissue for what we expose the animal to, because the species changed in the biological system. Okay? So later on, I'll give you an example. I say, a lot of people immediately say, well, I have this disease. And then when I have seen this disease tissue have very high level of this metal. So must be this metal causes disease. Now in pathology, we always shake our heads. That's called association. Causative relationship is not that simple. And I'm going to show you a little later. I give the metal. You measure the tissue. When you give it extremely high, rapidly it comes down. Symptoms occur somewhere down the line when the level is almost zero. So when you measure the tissue level of that toxin, it's gone. But the damage start coming up. We must understand hit and run could also occur. So metal toxicology could be more complex than we thought. Human exposure. And that slide was intended for our FDA friend. That is governmental. US EPA estimated for every 70 kilogram man, approximately 7 microgram per day is allowable. Dental amalgam, estimated 3 to 17 microgram mercury released per day. Eating fish, assume you eat it every day, 2 to 3 microgram per day. Other source, very low. What does the story tell us? The major body load of mercury are from amalgam. All right? Now, that doesn't mean there's health impact, right? So, the mercury there. Now, let's look at this also intended for our FDA friend. Because they will say, how would you decide as a toxicologist, as a pathologist, as a scientist, something is concernable? How will you decide? I'm giving you any chemical. Don't worry about mercury, any chemical. I said, number one, we look at, does the chemical present in your facility? If it's not there, I don't care how toxic it is. What do I care? I'm right now in Nevada, Las Vegas. If there's some pollution in California, that doesn't concern this group. How potent is it? Very potent. There are toxicity, but not that potency. Potency and toxicity are different. Does the group, the people, the population, have the opportunity to be exposed to it? There's none. I don't care how potent it is. This population is not going to be affected. If it's exposed, what's the dose? Very high, moderate high, extremely low? How often? How long the exposure? After you expose for a certain duration, certain level, does the body uptake it? Does the biological system uptake it? We call it the internal dose, not the exposure dose. If you expose to a certain dose, the body don't take it up, the body has no dose, so the internal dose is 0. So would it being take up? And if it take up, how long does it stay? It come in, it go out, no problem. It come in and never go out, very slowly, problem. How about, is the population, a certain portion of populations, particularly high risk group, sensitive to it? Then they are the one that also being problematic. Does the chemical in human expose any history, any record that there are medical health problems? Okay. If we agree that is the criteria we're going to assess or examine any chemical for its risk potential, then let's look at mercury in the amalgam. Does it present? Oh, it's right in your mouth. Does it present? You tell me. It's a potent, it's one of the most toxic metal ever known to mankind. Does it have any opportunity to expose? It vaporize and leak out every minute, every time, every day, every week, every month. How about the dose? Yeah, very low per unit time. How often? How long? Continuously, as long you have it in your mouth. Now you tell me how long. 10 years? 12 years? Some of you may have it on 15 years or more. Biological half-life, very long. Very long. It stayed there, particularly in the central nervous system. Is there any group of people that's particularly sensitive to its toxicity? Yes. Pregnant women, elderly, and children. What does it tell us? When EPA, FDA, regulatory agency do their guidelines, in fact, I wrote the guideline on neurotoxicology assessment for EPA, the first guideline. I wrote it, they contracted to me. It is on adult male. You do have to identify a population. You cannot single. So adult male, 70 kilogram male. How about pregnant women, elderly, children? No assessment done. Is there any health issues? Oh yes, many of them. From occupational exposure, from environmental minimum light exposure, many report on human health issues related to mercury. I was delighted to and impressed to hear that smoking gun, American version, the cowboys smoking gun. The Chinese don't play with guns. We have this dripping faucet. Because our governmental colleagues will say, Louis, just a little at a time, body take care of it, okay? Don't make a big deal of it. I said, do you have a dripping faucet at home? Leaky pipe, one drop at a time? One drop, will it ruin your home? No. 2 drops? No. 10 drops? Not really. How about 1 drop per second, per day, per week, per month, per year? After 3 years, you get a living swimming pool in your home. Okay? Does it do damage? You tell me. 1 drop water, it's not going to cost much. Come on, you could afford that. Keep dripping. Look at your water bill. We pay for it eventually. That's the Chinese version of the smoking gun, called dripping faucet. Now, we just phenomenalizing that. Does it really happen that way in nature? That water, is that powerful? That is a rock in China. Dongtinghu is one of the lakes there. A lot of people go to see it. They called it Tai Chi hole. You know, Tai Chi, people, it's a very soft style of Qigong. The Western, the yoga, Chinese Tai Chi. They showed drop of water, thousands of years, 10,000 of years, million years. There's a hole there. Showing softness ruins the hardest rock. The Western saying, you may have put the last straw that break the camel's back. The straw is very light. You put a straw on the camel's back, nothing. The camel's strong. You can even ride on it. There's always the last straw you put. The camel collapse. Our human body can take care of toxins. That's why we have defense system, antioxidant systems. We have the liver. We have defense immune systems. But to a certain point, that it cannot take it anymore, then you break the system and therefore adverse health effects. And this, again, I hope my learned governmental colleague could understand. So, as a scientist now, not just my personal opinion, but it's a scientific opinion that mercury in dental amalgam constitutes a definitive health risk. Let's look at basically how mercury does certain damage. And later on I'm going to talk about the cardiovascular, so I use this. Of course, there have been many other mechanisms. When I was directing the graduate program, I had many graduate students, and each of them assigned a project, and each project looking at different actions. either mercury affecting protein synthesis, mercury affecting mitochondria, mercury affecting different things. Student asked me, Professor, actually which is the mechanism? Each of us published a paper on the mechanistic. So I finally draw them an elephant. I said, you are holding the leg and he is holding the tail and someone holding the trunk and so on and so on. Which one is holding the elephant? Each and every one of you. Put your action together, that's the entire elephant. And here too, now I just single out mercury influencing mitochondria, the powerhouse. Mitochondria, we call it the respiratory center of the cell. There's another place we always use respiratory, it's the lung. Respiratory organ, right? Why? It's the place utilizing oxygen, called respiration. When they use oxygen, particularly the inner membrane, doing the cytochrome C transport to create energy, creating ATP, the energy source for the entire cell, and therefore tissue, and therefore organ. If that mitochondrial membrane are being affected, either depolarized or auto-oxidation, then it influences a series of events. Disrupting calcium hemostasis. Yesterday, that in the iodine lecture, we heard about glutathione, antioxidation system, lipid peroxidation, free radical generation. All this spelling what? Oxidative stress. When you have oxidative stress increasing, the body's antioxidative machinery cannot take care of the problem anymore. The last straw that break the camel's back occur, collapse. Okay, now that's one of a major way that cells are being affected by mercury, particularly in the cardiovascular system. And here again, mentioning in different organs, different form mercury may be playing a major role. And when we look at cardiovascular, inorganic, organic mercury is important, and mercury vapor, obviously, very rapidly transforming into inorganic is involved. Today, I just going to present to the group here, because most of you are dental physicians who appreciate human episodes. We look at, is this what you talk about happening in human? At least in animals. You show me some tissue cultures, a test tube. You can make anything happen on a test tube. You put some sodium chloride in it, or the cell dies. So should we start eating without salt, salt-free? Show me in human situation. Show me in animal system. How do they handle? And when we're thinking of cardiovascular, the heart is the major. And coronary heart disease, myocardial infarction, MI, or heart attack, many people call it. Using rabbits, large animal, and also the cardiovascular system have been well studied. Exposure the animal to mercury vapor, similar to dental amalgam releasing form of mercury. You get irregular rhythms, you get clotting in the blood vessels, therefore thickening of the inner portion of the heart, also some injury to the heart muscle, endothelial damage, inflammation in the aorta. That is on histology on animals. Now, human study, a very large study, 2002. 9 countries involving in Europe, 600 some people was invited to the study, And what they find is looking at the toenail mercury. Toenail is very sulfhydro-rich, SH. And they don't use shampoo. So there's least contamination. So that's why I use toenail rather than hair, because argument is hair is exposed to the ambient air, you use shampoo, how the hell I know? I just wear my socks. I don't think that will contaminate my toenails. So that's a good study. So when I look at studies, many times when we present our argument on studies, be very careful, because the other side is going to pick on your methodology to start. You pick the wrong group, you pick the wrong tissue, your sample is nonsense. So I don't even have to look at your data. Okay, and here, people have the first myocardial infarction heart attacks, on average, have 15% higher toenail mercury than controls. And on their fat tissue, the DHA is the fatty acid, is a good fatty acid. If it's low, then it also may correlate with myocardial infarction. So their conclusion is, indeed, the mercury burden on the body burden, reflected from toenail analysis, has a strong correlation with myocardial infarction. And if you take that DHA level into consideration also, that slope is even steeper. So this is the last study by Guella, 2002, and other study approximately the same time also demonstrate that minors, why do they pick minors, mercury minors, high risk group. If you take a very general population, the significant difference could be marginal. You cannot demonstrate a point clearly, definitively, non-argumentatively. So if you pick exposed group, high risk group in occupation, and they are minors, they are high risk, and looking at their cardiovascular related health problems, hypertension, chronic heart disease, renal disease, and cardiovascular accidents, also myocardial infarction, higher than control, all of them. So again, there is a human or epidemiological indication that there is an association between mercury level in the body or exposure, that's high risk exposure, to cardiovascular related clinical problems. Other study in Finland demonstrates a similar thing, urinary hair mercury with cardiovascular disease, hair mercury when they more than 2 microgram per gram, then the myocardial infarction rate is double or even to about 3 times higher. So those are all significant indications. And when we're thinking of myocardial infarction, at least we thought of 2 basic issues. You don't just come, boom, just like that. 2 things happen first. One is the coronary artery change. The coronary artery are the blood vessels that supplying blood to the heart muscle. If that problem, the heart muscle, of course, lacking blood supply, oxygen, therefore infarction. Okay, the second thing is hypertension. That's why a lot of us here, I'm sure, taking anti-hypertensive drugs. And looking at carotid atherosclerosis, thickening or hardening of that heart artery, and then indeed, higher, studying over 1,000 people, high mercury level in the hair, correlating with thickening of the carotid artery. And also they find when hair mercury is high, the blood low, the HDL cholesterol is also lower. That's the good cholesterol. Hypertension, higher mercury, also higher hypertension. And what they think is because mercury is SH-rich enzyme lovers. They will bind to sulfhydryl groups. And one of those enzymes is called S-adenosyl methionine, SAM. That is important for methacrylation of catecholamines, such as this. And those, many of you know, regulate blood pressure. And indeed, in chronic mercury intoxicated people, there's an increase in catecholamine in the urine. That means there's not being methoxylated. And mercury, of course, related to renal function dysfunctions, and that will also induce hypertension. So now we have the human study, but some animal study, both of this demonstrating the correlation, positive association of body burden on mercury and vascular disease. How about a dental amalgam? No study done. The minors, yes. The public, they just have high mercury, they don't know from where. So I personally would say, well, is it important for this group to think about? To say, is cardiovascular disease, any one of this, more prominent in old-time dentists? Why I say that? Because now, the modern dentists, they don't mix up the amalgam anymore. They buy these capsules. But the previous generation, they did when they were younger students. Do they have higher incidence of cardiovascular related problems or multi-filling population versus only one or two or less? Do they have a difference? I think if we find out what has been done, and when we have our course, how are we going to link this gap? Because there's no information. We cannot jump and say, look at the minors, that they have high mercury, therefore they have higher heart disease. Oh, people toenails, when they have higher mercury, they have high disease. That is the basis or logic for us to launch this type of study. When we don't have any preliminary data, why should we spend all our effort and money to do this? But when we have those positive indications, this is worthwhile to do. And this answers the question directly, rather than borrowing other situation and reflecting our own concerns. Shift that story a little. Arsenic. And my intention of showing this also is how we as scientists, as investigators, when we want to follow an investigation, how do we go step by step to demonstrate an end? And when we say we want to study the mercury saturation, we many times just spot pulling some study here without a systematic approach, not to pull out the whole program. One thing leading to another answer the question raised before, and the third one answer the question from first two, and the fourth, so on and so forth. And this is an interesting study that I have conducted when I'm in Taiwan. Arsenic is a global toxin, including in the United States, because many countries has high arsenic levels. And Asia in particular, says Taiwan. Taiwan has a very unique problem called black foot disease. They have this arsenic endemic area, and people drink from the well water, and then they develop this problem. on the extremities. And the extremity being involving vascular collapse. And the vascular collapse, therefore lacking of blood supply, lacking of oxygen, and then gangrene, dry gangrene. And this is how it looks like. It turns black. On the fingers, why turns black? Blood leaking out. It's the blood clotting. When vasculature start leaking, blood leaking out, and then they will clot, and therefore no more blood supply to those areas, and the tissue will die. So it suggests to us the arsenic, besides many people thinking inducing cancer is a carcinogenic metal, cardiovascular is one of the big problems. So of course, in our group, we started an epidemiology first, always with human, and then go back to experimental. If there's no human episodes, how are you going to justify using experimental? And then how do you know the experimental results echo the human concerns? And here we do the same thing. We're human exposure to amalgam. We're human problems. Then we go back and verify and validate with experimental studies. And looking at diabetes on arsenic exposure on the endemic area and arseniaceous area, you can see the strict rise in diabetes. And when we're looking at vasculature, macrovascular and microvasculature, and men, women, these are with diabetes, without diabetes, and the yellow or the red one are the one in the arsenic area. And let's look at this one, easier to see. In all incidents, there were people living in the arsenic area, exposing to the arsenic water. Their vascular problems are significantly higher than the general population, particularly in women, particularly young women. Because people will think cardiovascular disease is aging process. Heck, don't blame everything on the environment. That's aging, man. It's just, we all get it. But starting at 25, 30 years old, unlikely. You see? That's right. Women is targeted. When we're thinking of the microvasculature, the extreme, same pattern. Same pattern. So when people exposed to arsenic, particularly in women, they are high risk. And so we staying here and say both macro and microvasculature are affected by arsenic. Women are particularly vulnerable and at very young age. Now, then give us the encouragement to justify and say, we want to know what's happening. We do a cell culture first, because immediately jump to animal. It's dangerous. Cell culture does not represent human, does not represent the system, biological system, but it does give a biological model. So we do it very fast just to be simple. We're looking at oxidative stress, glutathione again, okay? So we find that glutathione drops, oxidative stress increase. Well, does that happen in animals? In intact animal, in vivo? So we've fed the animal, the mice, with arsenic. Okay, those are the 10 microgram, 15, 20 microgram per kilogram. We force feed them with garbage. And as you see, that all the arsenic exposed animals with a rapid reduction of glutathione level. That means that anti-oxidation potential ability has been suppressed. I say, oh, well, maybe anti-oxidation is a problem and oxidative stress is the base. Well, we'll see. I say, okay, that's cell culture. Validated in animals. We actually did the rat and the mouse. It's always important to do two different either strains or species, so there won't be say only this will happen. But for a reason of time, I will only present the mouse today. And how do we decide whether the vessels are in problem? Leakage. Remember in breakfast disease, the blood leak out, the vessel, when they injured, the permeability increased, and therefore blood will leak out. And so we use leaking vessel as a criteria. It has been generally used, and it's a good index or indication for vascular injury. Now, that's my little mouse. I call it the blue ear effect. Very simple. The mouse ear, very thin, 2 flaps of skin. The vessel actually you can see it very clearly. And what we did is, we inject arsenic, tiny amount, into the ear, and then we wait. There's a time. And also from the tail vein, we inject a dye, a blue dye. When the vessel starts leaking, the dye will leak out, and therefore we see the surrounding tissue being colored. And indeed, look at that. Color, all blue. Argument. Well, you punch the needle and inject some arsenic into the ear, you break the vessel leaks, your dye leaks. It has nothing to do with arsenic. So we did the same thing on the other ear, injecting saline solution, no arsenic. Indeed, the puncture hole leak a little blood, so it will leak the dye, but no more, does not continue leaking. And they say, well, maybe you injected the saline and put fluid into the tissue, it's small tissue, increase the fluid pressure, and then damaging the vessels. It had nothing to do with arsenic. Okay? Oh, this one we just puncture a hole without injecting anything. And so we inject saline here, and just show you. Indeed, the fluid pressure would irritate the tissue and do a little leakage. But also here the same, would never be like that. So what we are seeing here are because of arsenic. We saw the leakage. Can we quantify it? A lot of people criticize us pathologists and say you can only qualitatively describe something. Can you give me quantitation numbers? Yes. We cut the ear out. We extracted the blue dye that leaked. We put it on the spectrophotometry. We can measure the leaked dye, and now we can quantitate the leak by time and by level. So this tremendous leak is not only what we see, but actually it's quantifiable. Well, you only see the dye that you extracted. Show me the vessel that leaked. I didn't see any vessel. You see how we do experiments? We anticipate criticism and attacks. Okay, I'll show you the vessels. We inject another dye called Indian ink. It's a black dye that when it will leak out the vessel and coat the vessel. So the leaky vessel will turn black. This is the control ear. This is a high magnification. You can see the vessel is still pretty clear. This is the arsenic exposed ear. You can already see the little black streaks. And interesting enough, we inject in the center and the leakage in the periphery. So it's not the physical trauma. And when you look at that in high magnification, all the leaky vessels are black. So now we can see the dye leak, we can quantify the dye leak, we can see the vessel, the leak. Question: is the leakage correlating with the arsenic in the tissue? That's why earlier I mentioned, we start measuring the arsenic. When we inject, very high, rapidly, it removed by the tissue. By 60 minutes, almost none. But if you remember in the last data, it is by 60 minutes, the leakage is the highest. So that's why I say, if you try to argue and say, so therefore has nothing to do with arsenic, or I have only to see arsenic increase and then we have a biological problem, then I correlate. Wrong. Many chemical actions were done. The chemical left the site. The damage continues. Cancer is one. You have a carcinogen. Then you have a tumor 10, 15 years later. You think the carcinogen is still in that tumor? I don't think so. You inject the arsenic. That is not physiological. Whoever been injected by the metal, expose it the way people would. Use it drinking water. All right? We will force the animal to drink. We will gavage. Why? Why don't we use a bottle? Because mouse or rodents, they're very smart. They taste the water. They don't like the arsenic taste. They will not drink it. They will avoid drinking it. So you never know which animal drink more, which one drink less, and you have very inconsistent result. People will criticize you and say, boy, your standard deviation is like this. Okay, we force feed. The animal drink the water. And rodent has a disadvantage, but an advantage to us. They could not regurgitate. Anything you put in the stomach stays. They do not throw up. If you use a dog, they throw up. You force feed, you walk away, they throw up. And then you don't have any exposure. So we force feed them. Arsenic feeding alone. Before I talk that, I will tell you. Very disappointing. We feed the animal with this arsenic for 8 weeks. And then we'll do this blue year thing. No blue year. So my assistant came to me, well, Professor, now what I'm going to do? I said, hey, look, those animals are expensive. We're not going to throw them away. I tell you what, why don't we irritate the ear a little? And then we compare control animal being irritated and then arsenic fat animal irritated and see if it leak. Why I'm thinking that? I'm just thinking, if arsenic weakens the tissue without actually showing symptoms, like immune resistance gone down, the person is just as normal and healthy as you and I. But if the weather changes, they're the first one to catch a cold under stress. So I'm going to stress them. I use a stressor, irritant, called mustard oil. I learned this thing when I was in high school. Good thing I still remember. You put the mustard oil on the skin, it irritates the skin and therefore the vessel will leak. So it's an irritant. So we put the mustard oil on, and on control and on arsenic fat. The lower bottom one are the one without mustard oil. We use mineral oil as our control vehicle. Oil put on the ear, so there's no leak. But when we use an irritant, that is without arsenic. That is different doses of arsenic, fat. Look at that. So under stress or irritation, the tissue cannot withstand challenge anymore. And that's another way that many times when we want to demonstrate a healthy fat, it's not simply by, see, it look normal, but can they take stress? And my colleagues and dear friend here, we take stress every day. We're not always so relaxed here. After this meeting, we have to go back to face the real world, we're in stress. And so problem could occur. Now remember we talked about oxidative stress on the cell cultures and also animals showing glutathione change. Remember our dear colleague yesterday talked about selenium, talked about iodine, oxidative stress. Mickey, later on this afternoon, you're going to talk about oxidative stress. Oh heck, I'm sick and tired hearing the term. Tell me what does not cause oxidative stress. Name a chemical that does not cause oxidative stress. And how can you tell me oxidative stress causes everything? How come other chemicals like iodine deficiency or selenium, copper, iron cause oxidative stress, does not have vascular leak? How come arsenic now I use has vascular leak? Is there something more than just oxidative stress, or oxidative stress just associated with it, but not the causation of it? Association and causative is not the same thing. How will I distinguish that? Or how do I know that oxidative stress is not the consequence of injury, rather than the cause of the injury? So I have to look at, is there a pathophysiological process involving? Like the mustard oil. What pathological physiology? Now, when we're looking at arsenic alone, we see nothing, right? We feed the arsenic, doesn't leak. We give an irritant, oh, it leaks like hell. What did the irritant does? What is the pathophysiological base of mustard oil causing leakage? And therefore, arsenic exaggerates that leakage. Mustard oil is well-studied vascular injury model compound. That's why the mechanism is well established. Mustard oil will stimulate the C fiber, sensory C fibers, that will release a substance called substance P, a neuropeptide. This substance P is a tetrakinase, will bind to the endothelial cell NK1 receptor. That will induce vascular leakage. I said, ha ha, if that is the case, and if arsenic would promote that, would arsenic do the same? So when they're together, they'll do the same. Or when it is alone, they'll also do the same. So we set our study. I said, okay, if I will block the sensory nerve, not let it release this substance P neuropeptide, then the leakage should reduce, wouldn't it? I had to ask myself, if that's true, it should reduce. Or if I find a competitor for this substance P, its competitor, together, then the leakage will also reduce because, for example, NK1 are the chairs. And if substance P sit on it, then there's an action. But if I find someone look like substance P, and also come in and rush and compete with substance P to sit on those chairs, then the chance of substance P sitting on it will be much less. So the effect will be less. Yes? The final deal is, these chairs, the NK1 receptor, if I turn all the chairs over, so no one sits on it. I don't care if you release substance P, there's no chair. Then the final effect should be less, right? And so if my proposal, arsenic, goes through this we call neuroinflammatory action, then all those three should be true. We have to test our own hypothesis. And that's destroying the nerve fibers, C fibers. There's a substance called capsaicin. If we expose capsaicin to the neonates when they are 7 to 10 days old, they would destroy those fibers. And then when they grow up, we can expose them to arsenic, and indeed, the leakage significantly suppressed. The second thing is, we use a substance P segment, 4 to 11 amino acid segment. It has a long amino acid sequence. We just take that one segment. It will do what substance P do by sitting on the chair, but it has take no action after sitting on it. So it will compete with substance P. And with that, the leakage also much reduced. And the final thing is we use a chemical to block the NK1 receptors and then expose to arsenic, it also reduced. So the story now here tells us is arsenic inducing vasculature damage is through a pathophysiological mechanistic base, not a direct attack. So when we looking at the end physiological change, vasculature leakage, we don't see arsenic there. They don't have to be there. What the action is a physiological action. So when we're looking at mercury, it could be the same. Don't just looking at where mercury is the highest. If it's the highest, it is the cause. Too simple. Because mercury will do many action that is go through here, there, and then hit. And then you're try to see mercury there, you're not going to see it. So this is a good lesson for us to look at how metal behave on different systems, and when they cause problems, many times it is a indirect or a distant action. I learned this from neuro. When certain cells change, but the lesion is way over there, because this cell sends signals over there to do damage. So when you try looking at where the mercury is here, but how come the damage is over there, and here is the same thing. So I thank you for your attention, and if there's anything that I confuse you, please feel free to ask me to clarify. And I thank my able assistant doing all the slides for me, maybe the last slides that she made for me in my career, but I think it's a very interesting work that we have done.